Excellent. Thanks, June. And Howard and Neil, it's great to be here. I've been at Stanford now for about 5 years, a little over 5 years, and before then had been in Minnesota for about 20 years, building a muscle program, and prior to that was at UCSF for 9 or 10 years, training in neuromuscular disease. And so it's great to be here. I can't tell you how important this is. This is a phenomenally exciting time in neuromuscular disease. As Howard and Neil were stating, we are getting close to being able to treat FSH, and if we can work in partnership with the patient population and the FSH Society to move this forward, we can do that much more quickly. So it's really a pleasure to be here and to talk with you. It's more fun for me to kind of do this interactively. So this is going to be pretty schematic, hopefully to set a framework that might facilitate your asking some questions, because I would love to have more interaction. We'll have a Q&A session, plus I'll be here, the entire afternoon and happy to get cornered and talk with anybody about any particular issues you might have. As Neil was saying, you're the experts in this, and that's not just a cliche. That is literally true. You understand FSH in a way that medical practitioners don't, and really it's putting our heads together that's going to allow us to do the most. So I'm eager to interact with you. Just to state, as Stanford requires, that I do get a lot of support from a lot of different directions. I don't think any of them are in conflict with what I'm talking about today, but just to be upfront about it. In terms of the neuromuscular program at Stanford, I am just one of a large number of people. So in the past 5 years, we've put together a fairly substantial team where we have pediatric and adult programs that are meant to be comprehensive. So comprehensive continues to evolve. We continue to involve additional specialists in this, but we really are, again, eager to work with the community. The more patients we see, the more we can do to address all the issues of the community. I'm really happy that you're going to hear from another of our team members later on today, in Richard G., talking about exercise. So again, I'm going to be pretty schematic in going through this and just allude to a number of aspects of FSH, that some of which are going to be familiar to you, maybe some of them are novel. FSH is, of course, a disorder of muscle, and that is the condition, that is the feature that brings most of you to medical attention, whether it's one of a number of generations in a family that's affected, or whether it's a novel disorder in one particular individual. And it causes this predictable pattern of affected and unaffected muscles. It's one of the weird things about this. I mean, I don't know what your thoughts were about genetic diseases, but I always thought that since every cell in your body has the same DNA, that every cell should be similarly affected. And you know firsthand that that's not the case, because in FSH, there are muscles that are affected and there are muscles that are unaffected, even though they all have the same DNA, they all have the same genetic change. And that's telling us something. We're not smart enough to know exactly what it's telling us, but if we could take the message of the unaffected muscles and somehow use that to alter the behavior of the affected muscles, that would be enormous. That would be incredibly of value. So this is the kind of thing where we're still discovering novel things about this disorder. I mean, it's ongoing, and we're doing a number of different research studies to try to understand it better, which will then provide avenues of treatment. And we'll come back to that. But the pattern is really, really quite particular. I mean, you know the name. The name tells you something. It's named because of the effects on the facial muscles and the scapular muscles, but it spares relatively other shoulder muscles. It spares relatively neck muscles. It involves some arm muscles, but other arm muscles are never affected. So Stephen Blair is an amazing pianist, in part because he has preservation of finger flexors. So he can play the piano amazingly because those muscles are never affected in FSH. Now, why are they never affected? I don't know. I talked with other investigators in the field, and we've got some ideas and are investigating it. But that is really a peculiar feature of this one particular form of muscular dystrophy. The age of onset is extremely variable. We have some insight into that, why some children are affected at birth, and others. One of my patients I worked with in Minnesota was in a marching band playing the trumpet at age 65. So there's a mildly affected individual. And it runs the gamut. And he didn't know he was affected. One of his nieces was in a wheelchair by age 18. So that's another weird feature of FSH, is that it really can vary markedly between families and within families, so that you can have some family members who are unaware that they're affected, even though they are mildly affected, and other family members who are quite noticeably affected at an early age. So it breaks a lot of rules of what we're classically taught is the pattern of genetic disorders. The incidence is variably listed at 1 in 10,000, 1 in 20,000. Bottom line is we don't really know. To understand this better, we'd have to ascertain or identify people in a different way, in a more complete way. Right now, I'm sure there are many people that are undiagnosed. If you have a milder form of the disorder, it's really quite possible to go to quite an old age without getting diagnosed and attribute it to various other, attribute any weakness to various other possible causes, and never get an accurate diagnosis. So I think it's a very curious condition. One thing that is also purported in FSH is the time course, so that we oftentimes think of genetic disorders as being relentlessly progressive. And it is at least stated by some individuals with FSH that they will have good periods and bad periods where it seems like they will lose function, and then they'll relatively plateau for a period of time, and then they might lose function again. I'd be curious if does anyone here attest to that? Does anybody think that they've had that kind of fits and starts to the progression of this? I think, nodding heads or shouting, or I'm fine with this being more interactive. We're a small enough group that I think we can do that. But that's saying something. That's telling us something additional about the course of FSH, because something must trigger that. There must be a trigger for that, those stepwise loss of function, and then that trigger kind of fades away and you'll plateau for a period of time. Not everybody experiences that, so I'm not sure how robust a feature that is. It's certainly talked about enough by the neuromuscular practitioners, but this is an instance where it's hard for the doctors to know really what the course is. This is something where the patient and family population is going to understand that much better. And so this is, again, where we're going to be interested in communicating and working together with you. And then a last feature of this muscle presentation is the asymmetry of it. And again, as the condition progresses, those asymmetries might begin to become less obvious. But at one point in the condition, quite a few people will notice that they have, their right arm weak and their left arm relatively strong. Again, that's not what we think of for genetic disorders where every muscle has the same DNA. So it also is saying that there's something else that is triggering that or contributing to that progression. So I'm presenting kind of the classic features of this, but also some of the outstanding questions and why we are investigating this as much as we are to try to understand what some of these other mechanisms are. The genetics we're working out. The genetics is kind of the easy part, but it really does appear that there are probably some other elements to the presentation that we're still trying to understand. Okay, so what else is affected? We talked about the DNA being in all of your cells. So when people have a genetic disorder, we often think, okay, what other cell types, what other tissues, what other organs might be affected? And really, the bottom line there is that very few are. So that while in other forms of muscle disease, we can see a whole host of other things happening, in FSH, it really boils down to the skeletal muscle being the primary issue. Now, vision can be affected, the eyes can be affected. For the most part, that's either just a measurable phenomenon where we can look and see, yep, there's something funny there, but the people don't have any symptoms related to it. Or it can be more clinically significant in the more severely affected patients, mainly those who present in infancy or early in childhood. So it is possible, but it's not common in the vast majority of people with FSH. And the same thing about hearing. We don't see any obvious changes in hearing in most people with FSH compared to the general population, but we can in severely affected patients. And the same thing with the central nervous system. So again, in the very severely affected infants, we can see quite severe effects in some children, but others are really spared. Their central nervous system is normal. But in the vast majority of people with FSH, we don't recognize at present there being any significant involvement of the brain or spinal cord. How about the heart? The heart's a muscle. So, yeah, do you have a question? Is swallowing affected? I mean, it's indirectly affected in a large number of people. So that just due to loss of head position and loss of ability to control the position of the head, the tongue and pharyngeal muscles can be affected, but usually not as severely as the rest of the skeletal muscles. So in terms of swallowing, it's not as commonly affected. It certainly can be later in the course or in severely affected patients. And so we do sometimes need to work with patients to come up with alternate means of getting nutritional needs met. So like a feeding tube or something. But the majority of people with FSH will escape that requirement. Good question. Thanks. And anybody shout out. I mean, I'm happy with this. I know we have a Q&A session, so we'll address things there too. And I'll just stop talking when my time's up. So somebody just raise a red flag and I'll sit down and we can I have 5 minutes? Oh, wow. Okay, I was going to talk a lot more. Okay, 5 to 10. And then, it's the consequences of the muscle involvement are really quite significant. So mainly, breathing, mainly pain, so we can get into issues with neck pain, shoulder pain. Because of the weakness of the back muscles, the spine is not oriented straight in a number of people, and that increases the risk of getting compressive nerve changes. So you can have pinched nerves due to the weakness of the muscles, and all of those things are fairly common. The lower abdomen is affected, so that it's very common for patients with FSH to get into difficulties with constipation because of the lower abdominal muscles being weak. Let me just talk a little bit about the genetics so that we can understand this, and I'm going to go into this a little bit more in my talk later on research. It basically, to put this in a nutshell, it was a long slog figuring this out. It was quite complicated. But eventually it turns out that there's a bad actor on chromosome 4. This is still a somewhat simplified version of the model that we have, but still I think it pretty well holds up now. So there's a bad actor gene on chromosome 4 that if it's turned on, everybody carries this gene. We all have this gene. But if it gets activated too much, then the muscle is deteriorated. The muscle is damaged. So we don't want that gene, it's called DUX4, to get activated too much because the muscle will be damaged. And there are many ways that the body has developed to control it so that it is not overly expressed. First off, there are two versions of it, or more than two, but two to simplify things. A and B, so DUX4A and DUX4B. And on each of your chromosome 4s, you have one or the other of these. If you have DUX4B on your chromosome 4, that cannot cause FSH. You're out of the woods. That's not going to cause FSH. If you have DUX4A, that could cause FSH. May or may not, and we'll talk about what else controls it. So we can look and see if you have DUX4A, you are at risk of having FSH. And what keeps it under control, one thing, is that the region immediately adjacent to it is got this repeated sequence in the DNA that allows it to fold on itself. It tends to fold up, and that keeps the DUX4 kind of under control. So that by folding up the DNA, that keeps the DUX4 under control. It's not expressed and doesn't cause problems. And there's another part to that. There's another gene called euphemistically or in jargon, SMOOCH-D1. And what that does is it methylates or nails down those repeats. So it's kind of a double way of controlling the expression of that DUX4. So even if you have DUX4A, if you have plenty of those repeats that fold and the nails that hold it, the DUX4 won't be expressed. And if you have at least 11 repeats, you're fine, even if you have the DUX4A version of DUX4. Okay, what makes it turn into FSH is, so that's an unaffected individual if they have just that form. But if your chromosome 4 does not have as many of those repeat regions, it can't fold up as tightly, that increases the chance that DUX4 is going to be expressed. And if you have the DUX4A, that amplifies that, and you get too much of DUX4 and the muscle is damaged, even if the SMOOCH-D1 is there nailing it down. So even if you have those nails in place, the methylation nails, it's not enough to control it, and the DUX4A gets overexpressed and you get muscle damage. And that's called FSHD1. That's the most common type of FSH. Another way of doing it is if you have all the folds you need, you can have lots and lots of folds. They're ready to fold up as well, just in the way that they are meant to, but you're missing SMOOCH-D1. If SMOOCH-D isn't normal, then you miss the nails. You don't get the nails, the methylation nails in place, and the folding doesn't take place as securely. And again, the DUX4 gets expressed, and you end up with muscle changes, and that's FSHD2. How do we put this all together? I talked about this. In terms of diagnosing it, we can, if you happen to come to somebody who has seen a lot of FSH, they can diagnose it pretty much on the spot just by talking with you and doing an exam. But in other circumstances, we might need to do an EMG or even a muscle MRI. We're doing more. It says stop. 1 minute. The important point here is there really is no value in doing a muscle biopsy, which I'm sure many of you kind of rue hearing, because I know that a lot of people are still doing muscle biopsies. It's not distinctive, it's not diagnostic, it's not definitive, it cannot give you a final answer. It can tell you the muscle is involved. Sometimes it comes back normal, so it really has to be done right. And the answer is just doing the genetic testing that I just sketched out. So how do we manage this? Well, we work with people to help alleviate the symptoms caused by the weakness. A primary one is breathing, and Lee's going to talk about this. A key element there is your sleep. If one of the first signs of breathing problems oftentimes is a deterioration in your sleep, and you're going to be surprised if you don't know this to hear that the deterioration in your sleep means that you sleep too much. So oftentimes people think they're great sleepers. They're phenomenal sleepers. They can sleep 12 hours a day. They're the best sleepers. They don't think there's anything wrong with their sleep. If you're sleeping 12 hours a day, it tells you that the quality of your sleep is poor, and your body is sleeping longer because the quality is poor, and oftentimes that's due to the breathing issues. So that's a key sign of that. And then we work with people to help alleviate the muscle pain, and Richard is going to talk about the importance of exercise in this as well. There are other elements that come up. I mentioned the GI function, the facial weakness can lead to communication issues and other swallowing issues that we have a speech and swallowing therapist in clinic to help work on. And then we do work on doing proper and regular exercise to maintain function. And that gets very interesting. There's ongoing research to further refine what proper exercise means in FSH, but that's a key issue. And we think it's very important to avoid muscle injury. We do think that can be one of these triggers that I was talking about that can lead to some of the stepwise progression. So I maybe went a little bit over, but I'm going to stop there, and happy to stay around and answer questions. Maybe there's one question while we're shifting gears. Yeah, while Neil's coming up. It kind of depends on the family. If somebody in the family has been diagnosed with FSH, so the question is a clinical, I think this was the question, correct me if I'm wrong, that is a clinical diagnosis sufficient, or is a genetic diagnosis really necessary? A genetic diagnosis is really the gold standard. That's the definitive answer. I think, we don't have a treatment specifically for FSH. It's not going to immediately change what we do. There are different kinds of treatment that are coming, as we'll talk a little bit about later, and those will depend on your having a genetic diagnosis. We absolutely need to know before you can get some of the more directed therapies. Yeah. Yeah, that's a good question. Is the de novo inherited as an autosomal dominant? It can be either. So we can see what's known in the business as somatic mosaicism, so that you can actually not have inherited a genetic change and not have it in every cell in your body, but have it in some cells. And so it's variable. You can have, so like I've had patients who just had FSH in the muscle of their face, but did not have FSH in the muscles of their arms and legs. So it can be spotty like that. So when it's an unusual region of the chromosome that is prone to de novo or new changes, and that can happen either in the germ cell, in the sperm or the egg, or it can happen, in which case it'll affect all of your cells and then will be transmitted, or it can happen just in the tissues of the body, in which case it will not be transmitted. Okay?
Thank you very much, Dr.
Yep.